All right. Hey, everybody. See some people coming in here. We probably should have hit go live a little bit earlier. We were having some good conversations about some things early on here, but if just some administrative things, if you guys are getting in, go ahead. You can post comments and we can see that. So maybe post some comments of your name and where you're coming from, just so that we know that the comments are all working and that everyone can hear us. So we'll check that out. And I just get an email that we're live on YouTube as well. So you can put some comments on there in the YouTube as well. But tonight, I'm really grateful to have Dr. Brad Bley on here for Run DNA. And this is, before I give a little introduction, it's just, I really urge people to have strong relationships with the physicians in your area, especially the people that are pioneering what they're doing. We've worked together for a long time, and I've just been grateful to have a relationship that you can call somebody up and bounce some ideas off of. You can send patients back and forth, and there's trust there mutually that each is really trying to get the best for the patient. So that's something that I've appreciated and so grateful from Dr. Bley. And he's involved in a little bit of everything and a great resources on all things, but especially regenerative medicine. We were talking just a little bit about some of what he's doing here. He has his own practice in Wilmington and Towson, Delaware Sports Medicine. He's involved in academics, an affiliate assistant professor at the University of Delaware PT program. He's done through them and through others numerous publications, some on regenerative medicine as well as other topics. Done fellowships. He's CSCS, team physician of a number of high-level teams as well as local teams, chair of the Sports Medicine Advisory Committee for DIAA, or Interscholastic Association. So just really very involved and a great source of knowledge on this. So appreciate him being on. And anything I missed, Dr. Bley, or anything else we want to cover?
No, I think that's more than enough there. Thanks, Doug.
Yes. All right, good. So I see some comments coming in. So great. And we'll have this, and this will be available for viewing later. So I think just maybe to get started in a little prep for tonight, started seeing that regenerative medicine probably covers a little bit more than we think. So can you start by just giving us a little definition of like regenerative medicine and some of the things that fall under that?
Yeah, I mean, you'll hear lots of different definitions depending on what you look up. In orthopedics, it's often called orthobiologics strictly. In some spheres, it may be called anti-aging medicine, depending on what you're looking at there. So some of the treatments that we're using for a lot of the musculoskeletal issues are also used for everything from hair loss to skin issues. In fact, some of the stuff has really gotten its base in some veterinary medicine and a lot of cosmetic procedures, actually. So is being used obviously now, and what we're going to talk about here now is for a lot of musculoskeletal conditions. But essentially, regenerative medicine is a way to enable healing of the body naturally. And that can include everything from exercise, which of course is nature's best healer for everything, all the way up to doing PRP, platelet-rich plasma, stem cell injections, various surgical procedures, or in-office ultrasound-guided procedures, as well as kind of newer, over the last maybe 5 years or so, is extracorporeal shockwave therapy, as well to stimulate healing. But essentially, with any one of those, you're trying to harness the body's own healing factors and cells to create a positive healing environment. And we can go into more details as we talk here, but that's the general gist of what you're looking for.
Yeah, so I guess it really does cover a pretty broad range, and correct me if I'm wrong, but even something, like blood flow restriction and those types of things would fall underneath of this, because exercise is aimed at achieving that. And I guess when we first started talking about a topic for tonight, my brain goes to like PRP and shockwave and stem cells and those types of things when we think of regenerative medicine. But really, regenerative medicine is anything that looks to advance healing, with it. So,
Yeah. Yep.
um, yeah. So maybe if we narrow the scope a little bit, because we could talk about lots of different things when all of that is considered. If we
Yep.
start to think about some of those more traditionally thought of the PRP, the shockwave, the stem cells, all of that kind of stuff, what are the conditions that you see are really responding best to these types of interventions right now?
Yeah, so some of the biggest ones are some of our most stubborn ones that we struggle with physical therapy, with surgical options, with traditional, what I might call traditional injections, which is basically just steroid, is what most people use. So we're talking about the tendon injuries, the tendinopathies, those chronic muscle strain injuries, and osteoarthritis. And those are probably some of the biggest ones that we are looking at and using different sorts of biologics and regenerative treatments for.
Okay. And how do you decide which one goes where, right? Like, do you start conservatively and say, well, let's try something on that other end of the spectrum where it's like, okay, let's start with trying something non-invasive first. And how long do you give before you say, hey, it's time to start considering these others? I know it probably depends on the patient, the situation, how fast they need to get back, but is there a general rule of thumb along those lines?
Um, so it does really just depend on the treatment, right? So, and of course the pathology going on. And that's kind of the key part. One thing to be aware of is when one of the things that we're learning is there's no one size fits all. And it's the same thing with an exercise prescription or trying to train an elite athlete. What works for somebody is not going to work necessarily for somebody else. And so we are starting to learn that what works for one condition isn't necessarily a panacea and going to work for every condition. So when we talk about tendons, let's start right there. We're looking at tendon issues and chronic tendinopathies. The typical treatment or term that we used to use is tendinitis. And now we consider that to say it's really a misnomer. Even though that might be in all of our ICD-10 codes, it's still tendinitis. But tendinosis is probably a more correct term because you actually have very little inflammation happening within the cells or within that area of problem. So a chronic Achilles tendinopathy, you get that thickened, non-insertional, start with that there. You have a thickened Achilles tendon, 2 to 6 centimeters above the calcaneal insertion. And you basically, because of the watershed area there, you have decreased blood flow through that 2 to 6 centimeters, therefore not enough of your body's own natural healing to get to that area, which is one of the reasons we think Achilles tendons are susceptible to that. And so any of the treatments for looking at tendons, we need to not look at steroid like we used to and just say, oh yeah, let's just hit it with an anti-inflammatory, it'll calm it down and make it feel better. We really want to focus on, number one, a good strengthening protocol for that. Looking at the biomechanics of how they're landing. And that's one of the things I'm sure you've talked extensively about here, Doug, is how they're landing. I like to look in the office, how they're squatting, how they do with a single leg toe raise, how they do with heel walking, just looking at how are the muscles firing, and does the arch of the foot respond better to foot movements? Does it respond better to squatting or start to collapse when you have somebody squat? And then of course with some of the stuff I send patients to you for, with the gait analysis, we can see that at the higher levels as well of how they're doing with exercise. So that's where you start with everybody with the chronic tendon issue. It doesn't matter if it's lower extremity, upper extremity. I always look at the why. Why are they having the issue to begin with? There's some sort of mechanical breakdown. Yeah, there is anatomical and biological changes in every tendon, particularly, the Achilles tendon where we talk about that watershed area. But there's also oftentimes some sort of biomechanics that have led to that breakdown to begin with. And so before I even get into regenerative medicine and orthobiologics for stuff, I always want to make sure we're addressing that. I think any sort of intervention that you're going to do from a injection standpoint, or even shockwave therapy, which we'll talk about a little bit more, is not an injection, but you still are doing the patient a disservice by just doing an injection and sending them on their way and hoping they're going to be better. If you don't kind of correct some of the underlying stuff and have a good team, a good physical therapist with you that you can trust to kind of continue to work on some of the mechanics stuff down the road, that athlete is going to be back in to see you in several weeks or months, even, because they're going to break down again. So that's kind of my key starting point. Most people with a chronic tendon injury, I usually tell them, hey, we need to do at least several weeks to address these mechanics before we really want to consider other stuff. And we'll talk about kind of the timing stuff perhaps a little bit more when we talk about shockwave therapy and kind of how we might want to treat that. But in general, we want to approach it from fix the biomechanics, try to strengthen it, use natural excellence of exercise alone to try to get people better. And then if it doesn't get better, then how do we create that inflammatory response? How do we break up that scar tissue to get the tendon to heal?
Yeah.
So
Yeah, that's great. This is why we get along so well together here.
yeah,
Like
yeah,
addressing the mechanics of it is so important. It's just essential that you remove some of the causes first, because at the end of the day, if you're just looking, I'm sure there are some people that are looking for just a quick fix because they have a big event coming
yeah,
up. Or I know that
yeah,
I deal with this a lot with, hey, the Olympic trials are coming up, and it's like I need to run and I can't right now. So
yeah,
but if you don't address the underlying mechanics, it's not going to change a lot of the long-term outcomes with it. And they're going to think that maybe it
correct.
didn't work, when in fact, it probably just bought them a little time, which should have been an optimal time to start the healing process. So,
Correct.
um,
Yeah.
yeah, so let's jump into a little bit more shockwave here, because I think this
Yeah.
is something that is far more common. We're seeing it
Yeah.
even in physical therapy clinics right now.
Yep.
We're seeing it much more in physicians' offices. We're seeing a lot more. So let's dive into that a little bit here. So, how does
Yeah.
the shockwave help? What is
Yeah.
the method that does its magic there?
Yeah. So the hard part is the magic of it is basically that it is a little bit magic because we don't truly know exactly what is the big helping factor with shockwave therapy. So in my opinion, for shockwave therapy, and one of the biggest reasons to use it for that athlete that's going for Olympic trials or has a big a competition coming up of some sorts, before you might address the mechanics, is because it actually helps calm down the pain drastically and relatively quickly, compared to something like a PRP or tenotomy procedure or stem cell injections. Almost any sort of injection that you're going to do for a tendon, there's going to be a recovery phase, and it's going to take time until that pain gets better. And so that's time lost for training, time lost for potential atrophy of the muscle because they can't move it, and time lost to correct those mechanics to try to get them ready for whatever they have upcoming. So shockwave therapy, I think, is a great adjunct because you don't get that time loss effect. There's no needle involved. You're not putting a needle in an area. One of the fears with a lot of injections is kind of what is the proper time to rest before allowing them to get back to weight bearing, heavy load activities, because partially because you're putting a needle in an area, and there's a theoretical risk that that tendon could rupture further. Even though we all know that if you have a chronic tendon issue, that risk is there anyway. But a lot of physicians, and rightfully so, because we frankly don't have much data on it, are worried that, hey, if we let them run and try to train too quickly, it could do damage. We don't know if it will. We don't know if and in fact, it may actually be worse, because if we let that body just sit and not move, it could be worse. So we don't really know the answer to that. So the one thing I do like about shockwave therapy is pretty uniformly is almost everybody, we can let them just keep running, just keep going with it. So shockwave therapy, or extracorporeal shockwave therapy, is really the same technology that is used to disintegrate kidney stones. So lithotripsy. So it's been around for 40 years, and used for kidney stones for that. And some smart person decided, hey, you know what? It works really well in stones in the kidneys and urethral tract. So it probably works really well in tendons where we see a lot of calcifications oftentimes.
Mm.
And so it started to be used for that. The initial technology was actually very painful, and patients didn't tolerate it very well. Now they've kind of improved the technology enough that it is a lot more tolerable for a treatment. And there's two main treatments. So what you'll see, and I believe this is nationwide there, but really there's radial shockwave therapy and focus shockwave therapy. So radial shockwave therapy is the only one that can be outside of a physician office. And so that's what you'll see, I think, at a lot of physical therapy locations now.
Mhm.
Radial shockwave therapy is basically essentially a piston in like a little gun that essentially fires, and that piston then creates a sound wave. The benefit of that is it's a much cheaper machine, much easier to manufacture. And so that is one of the really nice things about it. And it seems to work very well for very superficial chronic tendon issues. The sound wave probably penetrates really no more than a centimeter to a centimeter and a half. So it's going to be beneficial for somebody with a chronic tennis elbow, golfer's elbow. Studies on radial shockwave for that seem to show that it's very effective. Focus shockwave therapy, you can get much deeper penetration, 6 to 8 centimeters deep. So it's good for that chronic gluteal tendon. It's good for that chronic hamstring tendon. It's good for that Achilles tendon where there is a lot of scar tissue. And focus shockwave therapy is really the only one that's been shown, if there's calcium deposits in there, that it will help break them up. Either we're talking about calcific tendonitis of the rotator cuff, we're talking about for the Achilles tendon, it doesn't seem to matter. It is effective. The question is how many treatments you have to do and the time for that. And that's a whole other topic for potentially another day there.
Yeah.
In general, most people need once a week treatment for between 3 to 5 weeks for most tendon stuff. If there's large calcium deposits within a tendon, that's going to take much longer period of time to really ultimately break up that calcium deposit. But the key thing, as I mentioned, with shockwave therapy, so as far as how it works, what we think it really does is that it increases all kinds of growth factors within the tendons themselves. There's multiple kind of proposed reasons for this. And Doug, I don't know if you ever share articles through this, but I can kind of send the basics of it. There's a really good article, I think from like about 2018 or so that I can send you the basics of that article, and you can maybe create a
Put
link to
that
that
in
or something
the
there.
notes even too for people listening, that they could link to some of that and check
Yeah.
it out as
Yeah.
well.
Yeah.
Yeah,
So
that's
that
great.
goes into a lot of the physiology of kind of how it works and the mechanism of action of the different types of transducers and what we think helps. But essentially, really a lot of anti-inflammatory effects, but also a lot of upregulation of various growth factors and also neovascularization factors. The way I explain it to patients for the basics of it is it does 3 things that we want to happen. One is it helps break up that scar tissue. 2, it increases blood flow to an area that does not have a great blood flow to begin with. And 3, and perhaps most important from an athlete in the middle of the season, is it helps with the pain. In fact, it seems to really help with like a lot of chronic nerve injuries. So somebody with like a chronic neuroma. So there is some data in neuromas of the foot that shows that it actually helps a lot, and is a really good treatment to help with the pain there. So we think it breaks up the neurogenic fibrosis, and essentially allows a lot of those little nerves that are growing from the outside of a tendon in, with all those little capillaries trying to get some healing in there. We think it essentially breaks up those nerve fibers in there that are causing pain, and shuts them down. And so people get drastic improvement in pain, which I love, because now we can get them strengthening. Now we can get them rehabbing, right? And that's
Yeah.
probably, the evidence shows, 85% of people with chronic tendon injury are going to get better with a good strengthening program.
Yeah.
So that's where I really like shockwave therapy now for tendons. And among all the biologics and regenerative medicine stuff that we talk about, believe it or not, it has some of the best evidence across the board for everything that it works really well.
Yeah. All right. 2 questions came to mind while you were talking about
Yeah.
that. What the first one is kind of about, the second one's a theoretical one, but the first one is more of a practical application of it there, right? So when I'm working with athletes, a lot of times the consideration is training load and how do we modify load based on these procedures. What is the recommendation for, let's just make it a specific example so that we're not all over the place too with it there. Okay, an Achilles patient comes to you, they're a high level runner or they're training for a marathon, and they might even be a recreational runner. At what point do you let them get back to higher intensity? Do you modify their intensity at all? Do you say, hey, no speed work for 3 days, try to do your rest days? Like because
Yeah.
the timing of that is a question that I get. My athletes always ask me like,
Right.
I'm going to get this. What day should I do it? Should I go from a hard workout
Mhm.
and go right to their office, or what are your thoughts
Yep.
there?
Yeah. So specifically, are we talking about shockwave therapy there,
Shockwave.
or
Yes, yeah,
okay?
shockwave therapy.
Yeah.
Yeah. Yeah.
Yeah, yeah. So, I mean, just before we go into too much detail on that, and this because this
Yeah.
applies to all regenerative medicine, is we want to think about the healing phases of the body in general.
Yeah.
So, if you guys remember the kind of the natural kind of curves of healing, we have this parabola of seven
Mhm.
to 10 days of inflammatory phase after any sort of treatment. And that's peaking usually around days 3 through 5, of course, and the same with any sort of injury. And then you have the proliferative phase, which anywhere from 4 to upwards of 12 weeks have seen for kind of the peak of that proliferative phase for any sort of injury. And then the remodeling phase, which is where you're going to get that macroscopic changes on MRI, on ultrasound stuff, which can be, it starts pretty early on, known as the remodeling phase. That'll go on for 6 to 12 months or so
Yeah.
afterwards.
Yeah.
So when we think about the physiology and natural physiology of the body, where we draw that line as far as aggressive rehab and stuff, if they've been running hard before a procedure and we're not doing anything to significantly disrupt the healthy tendon structure, then there's no reason they shouldn't be able to get back to running quickly.
Yeah.
Ideally, we want that proliferative phase to be going on to get good healing for the health of the tendon.
Yeah.
But if you're not disrupting the current tendon fibers and they've already been running on the tendon the way it has been,
Right.
then why slow them down for that? The only reason that I do initially is really for that inflammatory phase. How painful are they? I don't want anything that's going to change their mechanics and kind of lead to something else breaking down. But with shockwave therapy, the nice part is most people actually feel better the first 24 hours. Then they might have a kind of elevated pain response for 24 to 72 hours after that. And so
This
I usually
actually
tell them, hey,
that's,
yeah,
one of the
yeah,
questions we got from somebody. Joanna was asking,
yeah,
like, when do you find the onset of
yeah.
pain reduction, post-treatment,
There you
following
go.
days?
Yep,
So
yep.
we're kinda answering
Yeah,
that
so
there.
usually by 72 hours, they're already feeling better, and then they kind of start kind of slowly getting better, better than what they were, ideally before the first treatment with it.
Yeah, great. So
Yeah,
theoretically, if they're running on it, not have to like ideally, if you could get those 3 days just to get the maximum inflammatory response there before you were
yeah,
really maybe putting a hard effort onto it. And that's kind of
yep,
where we tend to do is like I say, try to give it 72 hours from the time that you
yep,
have it before you do a really hard effort. But they're going to be running. I mean, if you're running 100 miles a week, it's not much of a deal to go for an easy 5 mile run. That's almost
right,
like an active recovery from somebody else. If you're
yep,
running
yep,
20 miles a week, then you might want to rest for the full 3 days and
yep,
say,
yep,
I'm only running 3 or 4 days a week, so I should rest because it's
yep,
not used to consecutive loads as much there. So a lot of it
yep,
has to do
yep,
with kind of your chronic adaptation of the tissue already.
right, right.
Yeah. So then the second part of it is a completely theoretical here, and I don't expect
Hmm.
any. Well, I don't know. Maybe there is, and I just am not aware of it. Could you ever see shockwave being a preventative type treatment for somebody that's not experiencing pain? Like, if you do have a high level runner, would it be a standard protocol to say, "Hey, once a month you should get some shockwave for tendon health"? Could that? I don't know anyone doing that. I don't know that, but just as we're thinking,
Yeah,
like theoretically, could it be a preventative, just like somebody gets soft tissue massage, or
right.
we use compression, or we use blood flow restriction? Could we use
Right.
shockwave as a preventative?
I mean, that's a really good question. We've talked about, with some of the researchers at University of Delaware here that you know well, that we've
Yeah,
looked at some of this stuff and trying to follow out patients who might have the start of Achilles tendon pain. Some of the research that I'm part of right now is really looking at when does that onset of Achilles tendon symptoms happen. So we've gone back and started doing some ultrasound studies on patients that have been diagnosed with Sever's disease to say, hey, is there actually some insertional Achilles tendon changes happening. And we're trying to look at that to kind of see what is uh, where does that process start? And that's one of the things that's being looked at as well. I believe for patellar tendons in NBA players, there was some calls not too long ago for research proposals to look at that. Like, when does that tendon start to break down, and can we do anything ideally ahead of time to prevent it?
Right.
The hardest part is, of course, that we know from like even a healing phase that imaging often lags behind actual
Yes.
cellular healing, right? So then you can kind of beg the question is, okay, if we're already seeing changes in the tendon on ultrasound or MRI or anything like that, are we already too late to the game to try to address some of that stuff? Um,
But
but
theoretically, you
but
might be able to do
yeah,
that with monitoring, like
yeah,
performance-wise. If you start to
yeah,
see a loss in performance, it'd be really interesting to
yeah,
see. Like, I know with the NBA studies, they did a lot of IMU type things, and then could they
yeah,
see, is there a certain amount of training load that just cumulative? You're like, all right, we got to kind of clean this thing up here. It can handle X number of units, or we start to
yeah,
see, hey, your vertical is on average 12% lower right now. We recommend a rest day and
yeah,
shockwave and a week of low activity. It'd be, I don't know,
yeah.
I think it'd be really interesting.
Yeah, I mean, I think there's a lot of potential benefits to it, and I don't know what the ideal treatment is for those chronic tendons, but I think right now for those ones that are in pain, I mean, shockwave therapy for my patients is kind of a no-brainer. I mean, I will say I've used it on myself for tennis elbow, adductor injuries,
Right.
and I just really makes a big difference. And the patients really love the downside, of course, is not covered by insurance, but patients really love that it's a quick recovery, and there's other patients love that there's no needle involved as well. So and especially I saw somebody mention in the comments dry needling. Yeah, the great part about dry needling is when they come to see me for shockwave or an injection, they're like, wow, this is easy compared to dry needling. So
Yes.
but yes, so no, I think those are great ideas and something that hopefully we'll have some more information on as time goes on here.
Yeah. Yeah, it's interesting. I just, looking at that, getting ahead of some of these things, because, like you said, by the time that the tissue has changed, are we too late?
Hmm.
We've started this
Yeah,
process, and are we 3 months into a process? And
yeah,
we know that there's muted responses for like running,
yeah,
bone morphological principles that, like, after 3 months of running, like that bone response is significantly lower.
yeah.
So could you, and right now the suggestion is after 3 months, runners should take 7 to 10 days of no running just to allow the body to
Hmm.
increase its adaptation and allow it to respond better. But could it be, well, could you get to 6 months if you
Yeah,
did shockwave treatment for something? I know you can't shockwave the whole body or things like that,
no,
but we
no.
could, look at maybe some problematic areas here. So,
Yeah,
um, yeah, yeah. So it'd be interesting. Another good
yeah,
question from Joanna actually here too, saying,
yeah,
looking at photobiomodulation, laser therapy versus
yeah,
extracorporeal shockwave here,
yeah,
different results for different modalities. And I've actually seen some of my own evidence with some of this too, but I'd love to hear your thoughts on
yeah.
that as well. Yeah.
No, I mean, I think that's actually a really good question, and it's one of the things I've looked into considering adding to my repertoire is getting a laser in the office. I don't have that right now. I'm trying to figure out kind of, and part of the reason I haven't pulled the trigger on that is because I am trying to figure out where is that like ideal bridge? Like how do you blend them together to create the ideal treatment paradigm for that patient? So I mean, in a lot of the studies that I've seen for laser treatments, there is really more of an anti-inflammatory to help calm stuff down.
Mhm.
But how deep is that laser penetrating? Are we getting deep enough treatment there? And you would know more than me on that stuff, honestly, because I don't use it right now and haven't used much of it. But I do think, because I started to look into that, what is the role between the two of those, and can we find a way, ideally for patients with an injury, to get them better faster by combining those two treatments.
Yeah, just we do have a laser in my practice,
Yeah.
and we also use Tech-R therapy in my practice,
Yep.
and we've started to look at just the different types and who responds best to it.
Yep.
For the photobiomodulation, like you were talking about, in the presence of almost observable swelling, there
Yep.
is a very good response to
Yeah.
photobiomodulation with laser,
Yeah. Yep.
where somebody with a low level of fusion, somebody that has, like that early stage where the Achilles, there's still some swelling around it, there's a little pocket of
Yeah.
fluid there, they
Yeah.
really respond to the laser very
Yep.
quickly. It's
Yep.
a dramatic, like they get off the table, it's like, what was that?
Yep.
Um, we don't have the shockwave, but guys, we send them to you. Um,
Yep.
but we have the Tech-R therapy, and in an absence of swelling, when we're trying to bring an inflammatory response to it, we get really good response from the Tech-R therapy
Yeah.
with the windback unit. That is just something that gets very deep. You were talking about adductors. I
Yeah.
can't tell you how many people. There's a little bit of a unspoken issue in track and field right now, with lots of people having sports hernias,
Yep. Yep.
like
I mean,
adductor
that's yep.
issues.
Yep.
It's normally 1 or 2 sessions, and we're seeing almost a complete elimination of some of
Yeah.
the symptoms and pain with that.
Yeah, there's actually very good evidence too for osteitis pubis and for shockwave therapy for helping with
Yeah,
that. One of the things as well for shockwave therapy we haven't mentioned yet is with the focus machine. There's actually some good evidence for shin splints, for stress fractures, for non-unions, for sesamoid low-grade stress fractures, and even non-unions, that it can really help with pain drastically and promote healing. So have been a couple of studies here recently with medial tibial stress syndrome, general shin splint pain, that chakra therapy can really help calm that down. But that's what I thought with the data too, and that's what I had heard really with the lasers, is that anti-inflammatory component to it. I mean, I think it's a great adjunct for, yeah, like you said, that patient with that insertional Achilles who's got that calcification there that just rubs, and they get that little inflammation. The tendon's on its way to healing, but they just keep getting that rubbing. I think popping laser on there every once in a while is a great tool to help calm that down. So
yeah. Yeah, I think it's good. And then, sometimes modalities can be viewed as a four-letter word, but exactly what we're saying here is
yeah,
important. That and something to note in what you've been saying, and what we've been promoting in the past too, is that the purpose of it is to go back to your earlier part of the conversation and say, by reducing the pain, we're going to allow that person to do the exercise that they need to do, or to focus on their mechanics
exactly.
the way that they need to
Yep.
do. This
Yeah.
just accelerates the process there with it.
Yep.
Where
Yep.
if somebody comes to you and they're having pain, and they're having shin pain, and you can take away the pain quickly for them so that
Yep.
they can participate in exercises and start to load again, that's the key. And
Yep. Absolutely.
finding the algorithm of like what works when is really the goal with that, to get results fast with people.
Exactly. Exactly.
Yeah, so don't forget the rehab part of it too, right?
Yes.
And
Yeah.
that's, I know Dr. Bly's great about, referring and giving exercises as well, and promoting them to really get started with that. And that's important. So I'm going to ask another question or two, but if people start to
Yeah.
have questions, start to put them in the comments so that we can answer your questions as we go here. But, along that lines, we talked about a theoretical with the preventative maybe for shockwave, but where do you
Yeah.
see regenerative medicine going? Like where, I don't know if you want to talk about some
Yeah.
of the our stem cells, like what's the next big
Yeah.
one that's coming up, or where do we think that this is going to evolve to?
Yeah. So, I mean, going back to that initial conversation we had there. So, really, when we're looking at orthobiologics, it includes a massive, or regenerative medicine treatments. Orthobiologics are just kind of one part of that, really taking some form of the body's blood, bone marrow, fat, perinatal tissues such as umbilical cord, amniotic membrane, placental stuff, and trying to utilize that and process it in such a way that we can stimulate healing. Now, in general, and kind of why we got off the topic on shockwave therapy, for chronic tendon injuries, platelet-rich plasma, stem cell treatments seem to have kind of, over the last couple of years, really kind of gone by the wayside. More and more studies are showing that it doesn't seem to be effective for those treatments. And that's everything being looked at, and you'll see all kinds of different names for it, whether it's platelet-rich plasma, platelet-rich fibrin matrix, there's autologous conditioned plasma, autologous conditioned serum. And some of these are similar products, but maybe done by a different manufacturer. There's also autologous protein solution, alpha-2 macroglobulin. And then, of course, then there's the perinatal tissues, which I mentioned, and different types of adipose tissue derived treatments. So really, when it comes to the tendon stuff, a lot of those really haven't shown to be a drastic improvement in outcomes. Shockwave therapy has really been kind of far and one the leader with good level 1 unbiased studies, or should I say less biased studies overall, and more numerous of them, that seem to really help promote that healing there better than anything else. And there are actually some good meta-analysis and systematic reviews in the last couple of years that show that here. So the future there, a couple of things there. We haven't gotten on the topic much about arthritis here and talked about that. But osteoarthritis is different. Going back to our topic there about different treatments for different areas, right? For a while, actually going back to the PRP topic, we thought, hey, leukocyte rich PRP, having more white blood cells in it, was going to be the treatment for tendons, and leukocyte poor was going to be the treatment for arthritis. And that's what it looked like we were kind of trending there. But the only thing that's really stuck is actually that leukocyte poor PRP, platelet rich plasma, is definitely beneficial for arthritis related pain. Lots of studies now, meta-analysis, systematic reviews that show that there's actually good evidence for PRP, that it really helps drastically with pain associated with arthritis. So really, when it comes to arthritis treatments, and we're trying to avoid steroids, or we've tried gel injections, or we're trying to get something to actually that maybe make the body help heal itself up a little bit better, PRP is definitely the way to go for treatment for arthritis. There are a few doctors out there using shockwave therapy to help with osteoarthritis related pain. And because it does seem to help with like non-unions, stress fractures, bony related pain, it might help people temporarily with pain, but it's not really necessarily going to help the whole joint as a whole get better. So I don't use shockwave therapy really for arthritis unless the patient really wants it because they have one spot that's particularly tender or sore. Maybe we'll do shockwave therapy for something like that. But PRP is really the way that we do for arthritis. Along those lines, the stem cells, both bone marrow derived stem cells and fat derived stem cells, and there's a couple of different processes of how they're derived. We won't go into the details on all of that stuff there, but all of those actually seem to show that they're not as effective as PRP. So for some reason, PRP is way more effective than something that is what we typically consider stem cells. Right. And so some of that is thought because when you're actually obtaining stem cells, whether you're obtaining from the fat or from the bone marrow, there's actually very little stem cells that are obtained within that product. Very few stem cells are available. And then those stem cells, what they do is they arrive in the cell, disappear within 30 minutes to a few hours at the most, that they're actually in the actual joint, and then they're gone after they do their thing. Now, what they do is actually kind of the future of that, and I'll talk about that in a second there. But stem cells and fat-derived stem cells, amniotic stem cells, actually. So you may have heard people doing amniotic-derived stem cells or placental-derived stem cells a lot over the last couple of years. But as of, I believe it was as of January of last year, the FDA made all those products come off the market. So it's actually not available anymore because it had a temporary use permission that was supposed to, they're supposed to show that it had benefit, and hasn't really shown good evidence for it yet. So that's no longer on the market. So moving forward, and what I do for most of my patients is really look at PRP as an option. When we've tried everything else, PRP is going to be the best option for helping with pain. I have patients, especially my younger patients, if you can get them that are willing to pay for the cost of it, it's going to be healthier and better for the joint in the long run, for doing PRP. The future of what we want to do ideally is we ideally want what the concept of stem cells is. We want to be able to get that to go into the joint and not just calm down the joint, which is probably what PRP really does, helps restore that natural kind of environment there. And that's why it works so well. But ideally, we want those stem cells to regrow cartilage. Like
Right.
that's the holy grail, right? We want that cartilage defect to regrow so that you have appropriate cushion in there, and are able to not have those bouts of pain to begin with. So a lot of the research right now is looking more at exosomes. So when the stem cell goes into the joint, it immediately releases all kinds of vesicles, called your exosomes and lysosomes, that are released into the joint, and have all kinds of different growth factors within those little packets that are sent out. All of those are basically essentially signaling molecules for the joint. And so the future and what we're looking at, and actually a few years ago, a researcher, Dr. Kaplan, who unfortunately passed away in this past year, he came out and said, "Hey, we shouldn't be calling MSCs, which are mesenchymal stem cells. We shouldn't be calling them that anymore. We really should be calling them medicinal signaling cells, because
Hmm.
what then in the studies that are being done is how they're working is that they're actually sending signals to the rest of the body to tell it to get in there to heal something."
Hmm.
So what a lot of sports medicine doctors and biochemists, for that matter, think is kind of the future of it is being able to take somebody's stem cells, be able to grow those stem cells and kind of farm off or utilize the exosomes, and everything that they produce to concentrate just that portion that we want. We want that portion that's going to go in and signal that cell to, hey, start regrowing and start healing that cartilage up. And so that's where potentially the future is going to go. Unfortunately, with that right now, you can't do that at all because it's considered more than minimal manipulation. So the FDA does not allow that for any blood products there. Everything that is done has to be taken out and put right back in. So in order to properly get exosomes, you have to take it out, send it in a lab for a while, wait for it to be processed, and then re-injected at a later date. And we're not there yet. Hopefully we'll have some more research studies looking at that down the road.
That's kind of also the differentiation of what athletes can do from a doping perspective as well from a
Hmm.
lot of these things. Like, to be clear, just I know it's kind of a small consideration, but something,
Yeah,
if you take something out and put it back in, it's like not really a doping type thing. But if you
yeah,
manipulated it all before you put it back in, then
yeah,
not always, but can be considered along the doping lines there with it. But
yeah,
that's really interesting about the methodology, right? Because you have to ask
right,
yourself, why do stem cells help? What are they really
right,
doing? Are the stem cells turning into the new tissue, or are they telling the tissue, hey, get to work?
yeah,
And
yeah,
it sounds like the signaling is an important aspect of that too.
yeah,
So that's exciting just to see some
yeah,
of the future of that there, of what that could look like. I mean, you're essentially talking about anti-aging
yeah,
for some of those things too.
yeah,
If you can look at some of that, if you can reverse some of the cellular damage that happens with it. So,
yeah, yeah.
yeah, very good. All right, I saw one question, just stem cell related, just
Hmm.
loading after stem cell injections. I know you're not doing a lot of stem cell
Yeah,
procedures anymore with that, but it's probably going to be pretty similar to other. It depends. Something we talked about even before we started recording was
yeah.
it depends on what else was done at the time
At the time of the
of
treatment.
the
Yeah.
procedure, of the treatment there.
Yeah, and it depends on the specific pathology or problem that you're dealing with. For example, if you have a proximal patellar tendon where you often will get drastic and significant undersurface tearing of that tendon,
Mhm.
and you're trying to put stem cells or PRP or anything into that area to maybe try to get it to scar into that bone, you might be a lot more conservative with healing or with loading that area there. That might be a perfect case for blood flow restriction where, hey, you can keep that muscle strong, and keep loading it to keep the muscle mass there without putting too much load on the area that needs to heal, right? If you're talking more of just a general chronic tendinosis, minor intrasubstance tears, and you're not doing much needling of that tendon or breaking up potentially any healthy tissue, then there's no reason you can't load it relatively quickly. So that really comes down to good discussions with the providers that you're working with in your community to make sure that you're on the same page for each individual patient.
Yeah. Great. Well, this is really informative. It's helpful. Just we probably could talk on and on about lots of different topics
Yes.
and things like that here.
Yeah.
We did have one more question, but before we take the question too, just
Yeah.
what are ways that people can get a hold of you or more information, or like, because you're obviously a great source of information on some of
Yeah.
the stuff. Like, how do people get a hold of you or learn about that stuff?
Yeah. So you can certainly just check out my website. It's desportsmed.com, DelawareSportsMed.com. So desportsmed.com. And you can click on the contact us link and it'll go right to my staff's email, and they can let me know if any emails come in through that. That's probably the easiest way to do that.
Yeah, good.
Yeah.
All right, we'll probably take this one last question before we wrap up from Erica here. Just, thoughts on PRP for versus surgery for chronic partial proximal hamstring tears, because these can be problematic
Yeah.
at times here. So
Yeah.
it's an interesting consideration of how regenerative medicine can help out with that. Yeah.
Yeah, and I believe you and I have had several of these in the last 6 months here, probably.
Yes.
A couple of our female runners in particular that can't even sit in the car because they're in so much pain.
Yes.
That ischial tuberosity becomes so uncomfortable. So for those, as far as specifically PRP versus surgery, I'd say it's kind of a toss up as to kind of which one is going to be better. In my opinion, none of them really work great. Shockwave therapy is probably the best thing to do for that overall. As long as you're using you have somebody with a focused shockwave therapy machine, because a radial shockwave therapy is probably not going to get deep enough to get the penetration you need to get to really promote the healing of those tissue structures. That being said, I would most certainly lean towards PRP if I had just choose between those two. Anytime you're going to go in for surgery with somebody, you're going to potentially create scar tissue back there. If they're a high level athlete, they're going to get more scar tissue developing when you go in for surgery. There's no great evidence that surgery works well for partial proximal hamstring tears. In fact, probably not any better than rehab alone, based on the research. Probably just not even that long ago, maybe 5 years ago, even everybody with a complete proximal hamstring tear, the surgeons used to say, just leave it alone and not touch it. It's only been over the last several years with some newer surgical techniques that the studies have showed that no, actually, we probably should be fixing these, because otherwise they end up with some chronic weakness, especially in a runner. They get more of a flopping foot there if you don't fix that.
And
For that
mechanics.
partial tear, leave.
Yeah.
Yeah. What was that?
Yeah, yeah, yeah. Sorry, not to interrupt you there, but mechanics
Yeah.
as well. Like, thinking of some of the
Yeah.
shared
Yeah.
kind of recent cases there. I actually don't know if I've updated you on this person, but the like a gait analysis made a world of
Yeah.
difference of
Yeah.
reducing the cause on the cause of some of the stress on the tissue there.
Yeah.
Gait analysis has been a huge factor with that. Somebody with overstriding mechanics that is going into excessive
Yeah.
knee extension and then having to pull back down to get down to the ground there,
Yep. Yep.
even with slow running, that's going to be a big impact on it. So
Yeah.
I think it's kind of the combination of get the pain down, things like shockwave, needling, Tekar, those types of things can be very beneficial. That you're definitely considering depth of tissue. And I think that's a
Yep.
theme. This is like, consider the depth of the tissue that you're trying to address when you're looking at some of these things.
Yep.
But address the mechanics, because the patient we're probably talking about, gait
Mhm.
analysis, led to a little bit of a breakthrough for some of that as
Yeah.
well.
Yep.
Uh,
Absolutely.
yeah, yeah. So, well, great questions, really great thoughts, and just want to thank you for being on. Maybe reserve the right to call you back to the stand here for maybe some more because I think there's a lot more we can go through with some of the stuff and even dive into more specifically things for specific diagnosis or specific ones there. But I think it's important. I just really appreciate you being on because I do think it's really important that in the rehab space that we keep up with these options because people are going to be asking us. They're going to say,
Yeah.
what should I do for this? And we need to be able to understand that if they do have accelerated timelines, or a lot of times if you're the third or fourth provider that they've seen, they're going to need some assistance, and you can be a great resource to them, even if you can't affect their symptoms directly. If you can have a great referral source and somebody that can really understand what can be done for that person there.
Yeah, and I think you and I discussed this before. One of the big topics, even in among our sports medicine community, and at the last couple of conferences I've been at, is we need more research on what the post-injury or post-treatment rehab protocol should be, and because we really don't have that data, but it is hard, as we've discussed. It really depends on the pathology, which tendons involved, the specific procedure being done. So there's so many variables in that. And I always come back to, and that's why Doug and I get along really well. If we address the mechanics there, like if you're seeing them for the first time, think about the why that injury happened, not just following an assigned treatment protocol. Why did that injury happen for this specific patient? What do I need to address? I can't tell you how many people who have, lower extremity injuries related to, abnormal rotation through the thoracic spine with something they're doing. So, really look at that whole body. Don't just treat them for the knee. If they're coming in for the knee, make sure you're looking at everything else. So.
Absolutely. Great to hear it from the physician side as well here. So
yeah.
Awesome. Well, thank you everyone for joining. Thank you, Dr. Bley, for being on here, and follow us on Run DNA for YouTube, newsletter, rundna.com, and the podcast as well. Thanks, everybody.